Good afternoon, welcome everyone to this symposium, which is about patient cost surveys that are being implemented in a number of countries. By means of introduction to the topic, I just put up here one slide where the title tells you about one of the new NTB strategy targets that if you have been to any of the symposia before the conference started by WHO, or even last year Union Conference, you will have heard about the NTB strategy and this third high-level target, which is about ending catastrophic costs for TB-affected families. Now, this symposium is about national surveys that has a primary objective to measure the progress towards this target. But I wanted to remind everyone that actually it's not only about measuring progress towards this target, because these surveys have the potential to provide very important data to identify what types of costs that patients are facing, and that can help to identify the best interventions in order to reduce the costs, which have importance both for improving access to treatment, adherence to treatment, as well as reducing the economic burden for patients. The pie chart that you see in this slide is from a systematic review that we published some years back, just illustrating the types of costs that we're interested in. Not only the medical cost paid out of pocket, but also paying out of pocket for non-medical things such as transport and food, but also income loss. And these surveys are designed to capture all of these costs. And I'm going to not tell you more about the methodology because we're going to have that in one of the talks, and we'll have a panel of 5 different talks. One, it's about the methods. 2 talks are giving results of surveys from Myanmar and Viet Nam, respectively. And then we have 2 talks which are about the process of doing these surveys. So that's a brief introduction from me. I'll hand over to my co-chair, Anna Vassal, to say a few more words about the rationale and the importance of this kind of work.
Yeah, thank you. Yes, I'd just like to add a couple of things. I mean, we've known for a long time that TB patients have high costs, but the evidence we have is very patchy, and the methods we've been using in the past have been quite varied between studies. So I think this is a real step forward in trying to get some consistency and also trying to fill some of the gaps in some of the regions and areas that we've known very, very little about. The other thing I'd like to emphasize is this data can be used for other things as well. I mean, the world is changing in terms of making economic arguments, and it's really important in terms of the Sustainable Development Goals to use this information to say, well, actually TB contributes to development and actually reduces poverty. And there's been countries that we've been working in where we've been able to use this kind of data to make strong cases, not just to ministries of health, but also to treasuries and other partners who are now increasingly involved in economic allocations in the health sector. I mean, again, within the health sector, we're moving towards universal health coverage, and we're recognizing that generally the health sector has different objectives, not just to improve health, but also to have this financial protection role for families. And this is a key part of this and a key part of making TB part of this agenda. And finally, as Knut says, when you're working in the area that I work in, which is health economics, we do a lot of economic evaluations. And that field is also moving, and we're looking at both equity and efficiency improvements when we're arguing for specific new technologies to be adopted. And we can't do that without this data too. So it's really important, and it's really great to see, well, we hopefully will see some new evidence here and some new contribution towards methods. Thanks.
I realize we should introduce ourselves as well.
Right.
So Anna is working for?
The London School of Hygiene and Tropical Medicine, and I'm a health economist who works there.
Right, Knut Larnoth, I'm working in the Global TB Program, WHO. So now I'll hand over to my colleague from the Global TB Program, Ines Garcia, who is a technical officer there and deeply involved in this patient cost service. He will give you an introduction to the methodology and some experiences of implementation. Ines, please.
So with no further delay, I will focus the presentation on the standard methodology that WHO and the task force that was established for this topic has made available to countries for adaptation last year. and that has been adapted by 6 countries in 2016, some of which are here today to present either their first results or the process leading to the survey implementation. There's no conflict of interest on my side, so the agenda will focus on 3 items. First, on some sketches on the protocol and instrument to measure patient costs and the proportion experiencing catastrophic cost. Some common lessons learned from the first countries implementing, and then some advice to countries that are planning future surveys. Regarding the protocol and the instrument, they are available for download in the TB Impact Measurement Task Force webpage. The address is too small for you to see, but it's available there. And the survey has 4 objectives. 2 of them, the main ones, are first to document the cost borne by the patients and their households related to the TB diagnosis and treatment, and identify the main cost drivers to inform policy, universal health coverage policy, social protection policy, and beyond. And the second objective is to establish the baseline and to monitor progress towards 0% households with catastrophic cost. That is the third high-level NTB strategy indicator. We also have 2 other objectives related to some methodology checks. One of them is to determine the correlation between facing cost above different thresholds of annual household income and dissaving. And this in order to assess if the measure of dissaving is a sufficient metric for catastrophic cost. So 2 things. One on the word dissaving. So by dissaving, we mean taking up a loan, borrowing, or selling assets. And what this indicator, if this indicator would prove good, that would simplify very much the data collection, but it's yet to be proven. The last objective is to determine the association between cost and treatment outcome, and this with using routine cohort data. In a nutshell, the design of the survey, it's a facility-based survey, and it aims to be nationally representative. So we are looking at between 500 and 1,000 patients, so much larger sample sizes than studies done before 2015. And we are recommending a minimum of 20 clusters. The cost of these surveys, depending on what personnel time is covered and the size of the sample, has ranged from 30,000 to 150,000. And we expect the survey to be carried out once every 5 years, now to establish the baseline, and in 5 years to monitor progress towards the NTB indicator in part. And it's a cross-sectional study, so we have a single interview done, and we collect costs retrospectively, and we do projections within the treatment phase using the information from the patient within that phase and from other patients in order to estimate cost in the other phase. The estimated implementation time for the survey is around 6 to 8 months, ideally, if all the first administrative steps go smoothly, and the actual data collection takes 2 to 3 months. The questionnaire, in its field testing phase, which is the current version, which will be until March next year, it's long for now because we're also testing some elements, and it's 130 questions. It lasts around an hour, and 28 questions can be answered directly with a treatment card, and the rest, not all of them have to be answered by every single patient. It depends on the treatment phase and the type of patient. They will be actually answering different parts of the questionnaire. And there's an electronic format that we have developed using ONA, a web-based platform, and that platform allows very nicely to skip to the different questions depending on the type of patient that is being interviewed. And as I said, regarding extrapolations, there's extrapolations done with information from the patient himself and with other patients too. And during the field testing phase, which started in September 2015 and runs until March 2017, we would like countries not to delete any of the questions so that we are really comparing standard methods across, and we have elements to make further adjustments in the final instrument and protocol. The data collected allows to calculate the NTB indicator, the percentage of TB-affected households with catastrophic cost due to TB. And there are two indicators. The first one and main one is the percentage of households who incur in costs that are equivalent to 20% or more of the household's annual income pre-disease, and this relative to those on treatment. The second indicator is the percentage of households that experience any kind of dissaving relative to those on treatment. Now you see on the slide there are a couple of formulas that appear on the first indicator. They are there because the method that is used to calculate indirect cost, there's two options. One using what is called the output-related approach, which calculates the difference between the reported income after the disease and the reported income pre-disease. And the second way to calculate indirect cost is using what is called the human capital approach, which calculates the time loss by an hourly wage, where there's different options in which hourly wage to use with different consequences, methodology, and so on. The data collection instrument, which exists, as I said, in two formats, in paper and electronically, is composed of these parts. The yellow, so it's in yellow, the name of the part, and depending on whether the patient that comes into the interview is retreatment or new, and whether he or she is an intensive or continuation phase, they will be answering different parts. So for example, new cases that are in continuation phase would be answering part 1, part 2 in the informed consent, and then go straight to part 5. And the others, they would have to answer part 3 and part 4. And the number of questions are appearing next to the part. So you can see that the cost before current TB treatment, they are not, we don't ask many questions on that part, which might explain some of the results that you will see later coming up. I'm just going to explain what are the costs that are collected and which part is collected and which part is extrapolated. So we are collecting direct medical costs such as x-rays, medicines, doctors' fees, tests for adverse events, drugs to treat adverse events, and so on. What we call direct non-medical cost, which refers to travel, accommodation, and food expenses, and this not only for the patient, but also for the caregiver. We also collect information on the time loss and on the lost income. What I was referring before, we collect the reported, we collect information from income pre-disease and post-disease. And we also collect information on household assets, and this in order to provide another measure of income, this time estimated based on the household ownership. And lastly, we also collect measures, coping measures, and with the valuation. So anything that from borrowing to selling assets and so on. And these costs are collected throughout the whole treatment episode. So from the onset of symptoms until treatment completion. So there are some assumptions that are made up to as to the treatment success and so on. This is just a representation of the part of the data that is collected and the part of the data that is extrapolated. So the blue dot shows the interview moment, and the darker part is the data that is actually collected. So this is an example for new cases that are interviewed in the intensive phase. So for them, the data that is collected, since the onset of TB symptoms is inpatient and outpatient care costs, direct and so medical and non-medical, income loss, and also Dissaving. And from the treatment start until the time of interview, which has to be at least of 14 days, we are collecting also relocation cost and food cost. And the part that you see in yellow is the continuation phase. So we are not going to collect directly from the patient in the intensive phase what he thinks he's gonna be spending during that phase. We are actually going to extrapolate based on the data from other patients. The indirect costs are measured through two different ways. I already explained before, so I'm not going to go in more detail, but basically these two approaches might lead to very different estimates of the indirect costs. So in each country, we need to see what is more appropriate. The NTB, so there's also further methodology research that can be done with the data that is collected through this protocol and survey. In particular, on Dissaving, we can test whether it is a convenient proxy for catastrophic cost or not, what patterns and types of Dissaving have the strongest relationship with financial hardship and clinical outcomes, and also to consider whether any type of Dissaving is a proof or a sign of catastrophic cost, or whether a certain amount of would be compared to income. Also, we need to look at the extrapolation approaches, whether we are doing the right thing or we should adjust. And also on the indirect cost measure, how appropriate is it to use one or the other approaches to indirect cost measurement. And beyond the NTB indicator measuring, the survey allows to look at the risk factors for catastrophic cost, being an MDR, being in a certain setting, urban or rural, being in belonging to a certain income group, having a long delay to diagnosis. And also we can look at beyond the mean and the median and the quartile elements. We can also look at the maximum, the largest payments that patients experience. And also we can, with very little additional work, we can look at the link to treatment outcomes. The survey, as I mentioned, exists in an electronic, the generic one exists in an electronic format in this platform called ONA that was first used for the Ebola outbreak, and we have used it nicely, and the countries that are here today have been exposed, and some are using the web-based tool for data collection directly on devices. Some others are just doing paper-based and then using this tool for data management, because one of the advantages that it has, other than having a nice skip pattern, is that it also allows to extract the data in formats that can be analyzed with the statistical packages, including Stata, where we actually have developed a program to analyze following the methodology. In terms of the sampling methodology, we are looking at health facilities belonging to the NTP network. So by this we mean public, but also private that are notifying cases. And these take part of the sampling frame. And all patients of all ages, and that includes children, are eligible for the survey, both TB and MDR. and in continuation and intensive phase. However, children need to be accompanied by a guardian, and it'll be the guardian that responds to all the questions on the asset ownership and the income and the expenditures and so on. We are recommending the use of cluster random sampling, and if any country has an electronic case-based system, they can go for simple random sampling if the logistics and their budget allows. And we recommend involving a statistician for this exercise to make sure that the results can be extrapolated and be nationally representative. And there's actually a web page where you can do the calculation of the sample size, both for prevalence surveys and drug resistance surveys and for patient cost surveys. And the address appears on the slide. For the cluster selection, we recommend a minimum of 20 clusters and 10 patients per cluster. And this is, for example, in the Philippines, I think this is the case, and in Bolivia, where they are doing a subnational survey, they are also having very small size clusters. And as I said, it's facilities within the NTP network, and all the patients are eligible, provided that they have been on treatment for at least 14 days. And the selection of patients within the clusters is done proportional to the size of the number of notifications in the year prior to the survey. In terms of the common lessons learned, which will be less interesting than the ones that my colleagues from Myanmar and Vietnam will be presenting, and the other two countries. So just to mention that these lessons learned are based on a year and a half of implementation of this methodology, and we have 2 countries that have completed the survey, Myanmar and Vietnam, and there's other 4 that are on the way in 2016, and there are a number of countries that are embarked in preparation work, and they are looking for funding for this work for 2017 and 2018. So the challenges that we've identified so far have been linked to the fundraising and the contractual agreements with the research partners, having a timely ethics review committee application locally and to WHO regional office, reaching a successful balance between independent assessment and the NTP leadership, because we understand this work needs to be led by the NTP, but with a strong research capacity locally and remote support if needed. And the local adaptation of the survey has involved some external survey data collection too, which adds a bit to the, but it's no big deal, but it has added to the adaptation. And then selecting patients within facilities, I mean, you need clear SOPs and supervision, and you need to make decisions on if the facilities that have been selected randomly don't have patients coming very fast during the survey period. What do you do in order to make up for this? And then on the analysis, there's a generic code to align with the methodology, and this doesn't mean that the country doesn't have to make their decisions on the assumptions. So there's some critical appraisal of this code that has been developed. And the study design involves extrapolation, so this is not without controversy. And it's a cross-sectional study, so it's cheaper and anonymized patient records, but it can be challenging to do extrapolation. And Dissaving, we are not actually extrapolating the cost from Dissaving. And the instrument is long, so ideally we would try and bring it down to more sizable next year. And on the sampling, you need to have evidence on to inform the parameters that to calculate the sample size. In terms of the advice, I only have 2. One is to involve the relevant stakeholders, so NTP to lead on the process and result dissemination, to build on the local operational research capacity and local statisticians, and to tap on WHO and task force members for technical assistance, and to also involve funders through the country M&E plans. And if you want to tap on WHO and the roster that will be established next year in April 2017, these are the different areas that you can count on us for. And with this, I pass the lead on to my colleagues who will be, so there's 2 presentations, as Knut was saying, on results and 2 on process.
Thank you, Ines. We'll save questions to Ines to the end of the session. I think it's easier to address the right questions when you've heard about some results and some more processes in country. So I will now hand over to Dr. Sitouan, who is the National TB Program Manager in Myanmar and also the principal investigator for the survey in Myanmar, which is, as you heard from Ines, is the first one done with the new generic WHO protocol. So, Dr. Sitouan, please.
So thank you. Thank you, Chair. So my name is Dr. Sitouan, NTB Manager from Myanmar. So I'm going to present TB patient catastrophic cost survey in Myanmar. So this is the background of the survey. So we started the survey, the 25 clusters with 40 patients per cluster, nationally representative using the PPS sampling, the budget supported by the WHO, and we used 30 interviewers. Each interviewer is responsible for the 2 to 3 townships and the data collection from the December 2015 to March 2016. So these are the 25 survey sites among the stakes regions for the catastrophic cost survey. So in steps, we started with a joint proposal development, NTP, WHO, headquarters, and the country office for random site selections. Interviewer TOD in August, field testing in August, revision of the questionnaires, interviewer training, the pilot survey in September, advocacy and coordination in August, the conducting the actual survey in December up to the March 2016. So data entry was done between January to April 2016. We submitted the database to WHO in May 2016. So we conducted the TOT 2 days training workshop facilitated by the Global TB team in August 21st and 22nd. The participants were our NTP doctors, regional state TB officers, and WHO staff, technical officers. So we set up, at the same time, we set up the steering committee and the supervisor team in order to have the quality survey. And we reviewed and translated the survey questionnaires into the Myanmar language, and we conducted the role play among the participants for time spent for the data collection. So field testing was done in one of the districts in Upper Myanmar. Interview some TB patients covering all types of the category, MDR TB, childhood TB, and the drug-sensitive TB. And then we review the survey questionnaires based on the field test experience. Then we conducted one-day interviewer training provided by the TOD participants in Yangon during the first week of September. So our participants are TB specialists, district TB team leaders, data assistants, and community-based care supervisors. So role play was also done among the participants for time spent for the data collection. Then pilot survey was conducted in 2 townships in Yangon region by interviewer training participants. Each participant interviewed at least one patient in these townships, covering all types of the category, MDR TB, childhood and adult drug-sensitive TB. So after that, we conducted advocacy and coordination at the implementation sites. With the guidance of the National TB Program, WHO TB unit coordinated with the PSI and Myanmar Medical Associations to include their PPM GB clinics in the survey. So with the support of the states and regional TB officers, interviewers communicated and advocated to the respective implementation sites and PPM GB clinic in assigned clusters. So finally, we conducted the actual survey, started since December 2015. We used 30 interviewers, and the interviewing sites covering township TB centers, hospitals, urban health centers, MCH clinic, station hospital, rural health centers, and PPN private clinics. 40 public sites and 7 private sites, and 33 in urban and 14 in rural areas are involved in the survey. So in data entry, the states and regional TB officers and national technical officer conducted the data checking and cleaning with the close supervision of the state and regional TB officers. And NTP and WHO country unit coordinated with the global TB team for the further data checking and the validation after the submission in May 2016. So we received ethical clearance from the Ethical Review Committee of the Ministry of Health on 7 October 2015. This is the ethical approval certificate issued by the Ethical Review Committee. So for the survey, we used same methodology and the operational definitions that Ines presented. This is to show the descriptive statistical analysis on the survey sample by the type of the patients and overall age, sex, distributions, phase, treatment phase, HIV status, and previous treatment history, and the monthly household income distributions in US dollars. This is to show the summary of the DD cost in US dollar. We found the higher cost, especially in the patient's time and food, and followed by the medical cost. This is to show the distribution of the cost. Patients and caregiver time, 49%. Food and nutrition after the diagnosis, 25%. Medication, medical cost after diagnosis, 14%, and followed by travel cost, about 8%. About 65% of the TB affected household experience the catastrophic cost using the output approach, that is the direct cost plus changes in annual household income. About 59% with the human capital approach, that is the direct cost, direct cost plus the non-medical cost, and conservative approach, about the 40.7%, that is the direct cost only, medical, food, and the transport cost. And 64% of the TB affected household experiences some type of the dissaving, such as loan, borrowing, selling the assets, and use of the saving. This is to show that the cost for the direct expenditure of the household. So you can see the range about $50 to $2,500. Average cost ranging between the $400 to $1,000. Apparently, the high cost hugely contributed by the MDR-TB. That is the about 2,500 US dollar. So that is the red color bar representing the cost due to MDR-TB. So in conclusion, about the 65% of the TB-affected household face the catastrophic cost at the threshold of the 20%. Food and patients' time are the major drivers. MDR-TB patients are the most likely to face the catastrophic cost. So we evaluate the MDR-TB is a very hard economic burden for the country. Borrowing and the selling assets is very common, but it does not seem to be useful proxies of the catastrophic cost. Universal health coverage and social protection can eliminate the catastrophic cost. So these are the next steps. Survey results will be disseminated at Ministry of Health and Sports and other health-related ministries in order to use for policy making on social protection of the patients. We might consider for the additional support for patients' caregiver, and we have to follow up the treatment outcome of the survey patients in order to assess association between the catastrophic cost of their treatment outcome. And finally, we'll proceed for the publication. So this is the slide for no conflict of interest. And thank you very much indeed for your kind attention.
Thank you, Situang. It's good to see the data, but it's also, of course, taken at face value, quite worrying data that you're showing. I know that there were some surprises when you looked at the data. On the one hand, it's a very high number of people, high proportion facing large cost. And there were also surprises that a small part of the pie was the pre-diagnosis costers. So I'm not putting that question to you, I'm just sharing my own reflection. We will allow maximum 2 questions now for clarification. And there are a number of issues for wider discussion that we can save to the end. So 2 questions. Jaap, please.
Jaap Hoekmans, The Hague, the Netherlands. Thank you very much. I think this is a wonderful exercise doing these cost surveys, because it also makes us better realize why we are doing our TB control work. My question to you is, Dr. Aung, the labeling of catastrophic has come from Geneva with the cutoff point. Did you ask the families if in the Myanmar context they experienced this cutoff point also as catastrophic?
So thank you for your questions. This is the cutoff point, 20% is, actually this is the tentative recommendation of the WHO. In the Myanmar situations, this is a little bit high for the Myanmar context, but if the catastrophic cost, it depends on the cutoff point. This is, we use the 20% and more, but based on this cutoff point, the catastrophic cost is, it seems high. So it depends if the catastrophic cost threshold, we can, reduce, it will be increased, and we can increase the cutoff point, the catastrophic cost will be reduced. So in Myanmar context, it is high. The cutoff point is a little bit high for the Myanmar context.
Did you ask the patients?
Yeah. Actually, some patients, we ask the questions, but Myanmar patients, some patients, they can see what the cost in previous, but some patients, they cannot mention the cost.
Okay, if there are no further questions at this point, I think we should come back to the issue later on appropriate cutoff and how it corresponds or not to perceived consequences, and whether the perceived consequences are more trustworthy than the actual numbers. So now, thank you, Dr. Sitoang, and we'll move to Viet Nam. We have Dr. Hoi, who is Deputy Director Manager with the TB program in Vietnam, who will present the findings, or rather the preliminary findings, because the data collection finished just 2 weeks ago, I think, so it's, the analysis is not complete yet. Dr. Hoi, please.
So, good afternoon again. So, it is my great honor to present NTP Vietnam to present some initial result of the survey. So, as you may know that majority of TB patients in Vietnam living in poor household, and this study may provide us very good evidence on how TB affected socio-economic status of TB patient. And we mainly focus on 3 objectives of the survey. Firstly, we would like to describe the magnitudes and the main drivers of patient costs. And secondly, we would like to identify the proportion of TB patients experiencing catastrophic costs due to TB. And hopefully, we could design a standard approach for periodic measurement of financial barrier among TB. And we apply the guidance of global team, and we also did a cross-sectional survey at national level with 20 clusters selected in the whole country, and each cluster includes 36 patients, and all these patients identified from district TB units. Totally, we have 720 TB patients, and for the country, we classify into 3 regions. The north, we have 7 clusters. In the Central region, we have 2 clusters. And in the south, we have 11 clusters. And we follow the same guidance in selecting TB patients, those who are consecutively visit in the DTU. And for the patient, we include all TB patients, including TB HIV coinfection and MDR TB patient. And both intensive phase and continuation phase are considered for the survey. And we exclude unaccompanied children and people who are treated in facility outside NTP. So it is different from Myanmar. They include also private sector, but we have no private sector. And we follow the same data collection flow and methods. And we start to develop the proposal and adapt questionnaire in March of this year. And we start with data collection in August. And we completed data analysis last month. So now we would like to present some initial results. Firstly, for the patient profile. So majority of our patients are men, and the age around 40 to 50 years old. And the patient in incentive phase a little bit less than those in continuation phase. And we got very few patients with coefficient, NIVS coefficient. And majority of the study subject are in new treatment. And the average delay in diagnosis about 8 days. And particularly for MDR patient, it is a little bit higher. And for the detailed cost, so for before diagnosis, so the costs are majority in medical cost and patient time. But after diagnosis, so much more majority of the costs belong to non-medical costs and patient time. And in the total, patient spend 1,000 in median and spend 1,800 in average. And here we could see that when using direct cost measure as income change, almost 60% of household incur in catastrophic cost, and the cost hands between pre-diagnosis and after diagnosis. And using human capital approach, almost 80% of patients facing with catastrophic cost. But using output approach, we have less, only 60% of patients facing with the catastrophic cost. And in total, majority of patients, almost 70% of costs belong to patient time category, and post-diagnosis cost is much higher than the cost for pre-diagnosis. And separate actually, if we look at median cost breakdown, we see that majority of the costs are medical costs, and less for patient time, and lowest for non-medical costs. But after the TB diagnosis, patient time become majority, and less for other items. And if we look at catastrophic cost experienced by MDR status, we could see that percentage of patients facing with catastrophic costs very high, almost 90 and 100% in some methods. And only approach 3, we have almost 60% for the cost using categorized by household saving, this saving. And when we look at how patient coping to the cost, we could see that 60% of patient using loan or using saving or send assets, and almost 1/5 of the patient facing with food insecurity, and 75% of patients facing with work loss. And for financial impact, we could see that majority, almost 60% of patients facing with at least moderate impact, or even serious and very serious impact. And during the survey, we also facing with some problem like recall bias, duplicate records, and time consuming, etc. And we try to find some strategy to reduce the bias and the problem. And we have a very big advantage that we receive very strong support from NTP team at national level and also provincial level. And we got very strong support from WHO and other colleagues at different TB facility who involved in the study. And in conclusion, so in Vietnam, TB patients often occur with large costs related to illness, and patients incur almost $2,000 for expense during TB illness, including susceptible case and MDR case. And we have a shift in income between pre and post TB diagnosis, almost 50%. And patient time is a main driver cost due to TB illness, and accounting for 72% of the grand total cost before and after TB diagnosis. And using output approach or human capital approach, proportion of household incurring in catastrophic costs are almost 60% or even 80% respectively. So for the next step, we will do deeper analysis to design a standard approach for a periodic measurement of financial and economic barrier from TB in Vietnam, and we will collect and link to treatment outcome information, and we will using data from this study as evidence to advocate new policy in TB controls, particularly in social support for TB patients. Thank you for your attention.
Thank you so much, Dr. Hoy, for that excellent presentation. We can already see quite a few similarities between the two countries that have also quite a few similarities when it comes to the TB situation, the health systems challenges, and also the socioeconomic profile of the patients. Whether this is an element of validation of the methodology, it's too early to judge. It could also be some biases and methodological limitations playing out in similar ways in the two surveys that we can discuss a bit later. But let's have maybe one or two questions again for clarification to Dr. Hoy. Tom, please.
Hi, Tom Wingfield from Liverpool. Thank you very much for that presentation, the last presentation. It would just be really nice to know, not knowing your healthcare system, if the TB patients are treated in hospital or outside of hospital, and for the previous speaker as well, because obviously that may make a huge difference to your costs post-diagnosis, which are very different for what's previously been seen in systematic reviews where they've been divided really half-half between pre and post-diagnosis. But these results are really, really interesting. Thank you.
Okay. In Vietnam, we have a TB and lung disease hospital at almost provinces. We have 46 provinces. Among 63 provinces, we have a TB hospital at provincial level. And we have a TB district team at district hospital or preventive medicine center. So in many provinces, TB patients start with intensive treatment about around 2 weeks or even more, even up to 4 weeks or 6 weeks inside TB hospital at provincial level. Before we send the patient to the TB district team for further management. So we have opportunity to take care of patient at hospital setting at the beginning of the treatment process.
maybe just Ines, go ahead.
Yes, perhaps we could have some information on the number of the model of care that is behind the number of hospitalizations that was included, like what share of the sample includes hospitalization. And actually in Vietnam, DOT is once a week coming to the facility. But I don't recall now the number of patients that were hospitalized from the sample. Do you?
Maybe rather than answering that now, I mean, it's because you're still continuing the analysis, and this is one of the variables that is included in the data set. So you can actually look at the costs coming out of hospitalization, pre-diagnosis, and after diagnosis. And I think this is a critical part of the finer detailed analysis that is required to inform the policy decisions coming out of the survey.
Thank you.
Any more questions? Can you go to the microphone up there?
Thank you very much. William from LSHCM. My really interesting presentation and results, thank you very much. I'm just sort of trying to jump to maybe the step ahead and think of solutions for these costs. And I'm particularly worried by the MDR TB patient costs, where even just direct medical expenditures, 98% of patients are incurring catastrophic costs. What solutions do you have? Have you started to think of these? You talk about social support and those sorts of things, and I just wondered if you could elaborate on that for us a little bit.
Yeah, actually we could see that the proportion of MDR patients facing with catastrophic costs very high, 90%, even 100%. So in Vietnam, we are now trying to advocate for new social welfare policy to cover and to support the patient. And now we are piloting social support package for MDR patients in 3 provinces. And we will evaluate the result of that of this pilot very soon. And we have a new initial evidence to convince with Ministry of Health, Ministry of Labor and Social Affairs and government to provide more support for TB patients, especially MDR cases. And we also, on another hand, we are now starting develop social and charity fund for TB patients, so that aside from potential government support for MDR patients, we have another sources of funding to support for TB patients in general, and particularly for MDR patients. Yeah.
Thank you. I think we need to move on to the next presenter now, but thank you very much. So the next presenter is Deborah Petrosley. She works for the London School of Hygiene and Tropical Medicine as a research fellow and a PhD student. And she's going to present on the process of setting up these studies in Ghana and give you some indication of her reflections on that and how it's gone.
Thanks, Anna. Good afternoon, everybody. I have no conflict of interest. So we're now moving to Africa and West Africa and Ghana in particular. And I'll start by describing and giving you a bit of background about the study setting, Ghana, and then move on to illustrate the process of designing and planning this study. So we thought that we were doing quite well in controlling TB in Ghana. All the main TB indicators had declining trends over the last few years. Notification rates were quite stable. But in 2013, when Ghana undertook a national TB prevalence survey, the findings actually showed that Ghana had a generalized epidemic with a burden which was 4 times higher than we previously thought. And this survey also highlighted that there are considerable barriers to accessing and adhering to TB care. And for example, amongst patients who had at least a cough for 2 weeks, they mentioned that not being able to afford TB care or being able to take time off work to go and see like a doctor were one of the main reasons for not seeking care. And also the facilities were like considered to be too far in some cases. So at the LSHTM, we've been working since the beginning of 2015. We've been working to provide technical support to the National TB Control Program in Ghana. And we've been asked to model the current epidemic and in the implementation of the interventions that are part of the National Strategic Plan, as well as the concept note, as part of the reprogramming of the current Global Fund grant under the new funding model. So recently the World Bank has reclassified Ghana as a lower middle income country, and this is due to the fact that for the past 2 decades, Ghana has experienced quite a steady economic growth. We can see the impressive GDP growth in the last for the last 10 years, without even a peak of 14% in 2011. And poverty has also decreased alongside an increase in economic growth. But the concentration of poverty remains in the northwestern part of Ghana. As you can see on this map, the red shaded areas are the poorest parts of the country, so the north and the northwest in general. And inequalities remain, and actually they've worsened in the past decade. And poverty is acknowledged to be a driver of the TB epidemic in Ghana. And there was a previous study conducted by Mack et al. And published in the IJTLD in 2013, which used the predecessor of the current generic WHO tool, which was a tool to estimate patient costs, which was developed by KNCV and USAID and other partners. And this study found that TB-affected households spent over 100% of their monthly household income on healthcare, and that individual mean income of TB patients dropped by 79% after being in care. So as part of adapting the generic tool to Ghana, we undertook a mapping exercise of the social protection landscape in Ghana. And this is partly to answer to William's questions like what's next? How can we answer to this, to the magnitude of this cost? And a couple of things I'd like to say about it. So the social protection system in Ghana is quite well developed, and it's been expanding since Ghana's independence in 1957. And it has been coexisting with a traditional social protection system where support to individuals was coming from the extended network and families. But this has been slowly been weakening due to migration to urban settings and mainly because, and internal migration and urbanization also. And there are 3 things I'd like to point out on this infographic. So the first one is, the first milestone was in 2003 when the National Health Insurance Scheme was launched by the government of Ghana. And it's based on a contributory model, so that means that it covers the formal sector of the economy. And it now covers 34% of Ghana's population, but there are plans to expand this further. And there was a study conducted by Kuzi et al. Very recently in 2015 that found that this scheme provides significant financial protection, although it doesn't eliminate all out-of-pocket expenditure. The other things I wanted to point out is that the same year, in 2003, the NTP, recognizing that poverty is a major driver of the epidemic in Ghana, launched the Enablers Package. So this is a TB-specific intervention. It's not general social protection scheme. It's specific for TB patients. And it provides TB patients between $100 and $65. So at the beginning, when it was launched, it was $100, and now it's been reduced to $65. And for 6 months per patient. And the composition of this basket normally varies, and is tailored to the needs of the patient. So if a patient needs more support in terms of transport, they get bus fares, or If they need, for example, to cover the insurance premium, then that's what's given to them. And it's not only the patient that gets money or in-kind transfers, but it's also the clinic. So the rest of the 50% is split 30% for the clinic staff and 20% for the health facility as an incentive. One of the problems is that it's not being implemented in a uniform way across the country, and therefore it's been quite difficult to monitor and see whether this had an effect. The other problem is that the Global Fund has now pulled out of the enablers package, so it's now supported only by local funding, which are not enough. And the last thing I would like to point out on this slide is in the top right corner. And so the latest National Social Protection Strategy in Ghana has launched a number of social protection interventions and programs. And amongst these is what is called LEAP, which stands for the Livelihood Empowerment Against Poverty Social Grant Scheme, which is a conditional cash transfer given to extremely poor households. And in fact, the selection of the houses is quite complex and really well developed in Ghana. And interestingly enough, the government of Brazil is amongst the funder of LEAP. So now moving on to the adaptation process of the survey to Ghana. So in addition to the primary objective of determining the magnitude of patient costs and drivers in Ghana, we also thought about adding 3 secondary objectives. This is a schematic. That's just an adaptation of what Inessa showed earlier. So the first 2 objectives, the first one relates to assessing the nutritional status of patients in terms of BMI. And this is because the NTP in Ghana believes that 50% of their patients are malnourished. So we thought this would be a good opportunity also in terms of maybe exploring what to do next in terms of social protection interventions to mitigate the cost that we might find during the survey, to actually get a better idea of that. So we hypothesized that maybe patients with lower BMI might incur higher costs, and so we included that. And this is something that should be recorded on the patient's treatment card. If this is not the case, we're going to actually measure that. And if it's recorded, we're going to validate what we are measuring during the interview. The second objective is about facility-based case finding. So Ghana has just started actually to roll out nationwide intensified case finding, so of clinic attendees nationwide. And we thought that maybe it'd be interesting to look at whether patients picked up through ICF rather than passive case finding incur higher or lower levels of TB-related costs. And because we think maybe if they are picked up through intensified case finding, this could reduce their delay to being diagnosed and then put on treatment. And then finally is what Ines also mentioned, is about assessing treatment outcomes of TB patients, how these are affected by different levels of costs. So now I'd like to briefly describe the process of sampling for this survey. So Ghana has 10 regions and just over 200 districts. Notifications are in the range of 15,000 and constant. And we decided to use a district as a sampling unit for our survey, rather than an individual or the health facility. And typically a district in Ghana with a population of 100,000 inhabitants has one district hospital where the diagnosis is made, and 5 health centers, and between 10 and 15 of these CHIPs, which are community-based health planning and services, in addition to NGOs facilities. And patients get treatment at all these levels of facilities. Then, based on the study, in the 2013 study by Mark et al., we made the assumption that 40% of patients were experiencing catastrophic costs. We used the online application that Ines described, And we decided to go for 25 clusters, and these would have 29 patients in each of them, and that would give us a sample of just over 700, so 725. Now, what the prevalence survey has shown is that Ghana has a generalized epidemic, but we also know that regions in the north of the country have the lowest notification. So we were a bit, and we know that there are huge barriers to accessing care. An example at the NTP thinks that there's a 30% barrier to reachability because only 50% of population is actually reachable by the health service, and 60% of them accept screening. And so we were worried that we wouldn't be representing and giving a true picture during the survey. So we further, when we manually adjusted the initial selection of clusters to ensure that there was a good representation of the north of the country. And also for logistical and money reasons, clusters that had less than 100 TB cases notified in 2014 were grouped together. And this is again an example in the northwest of the country. So we are planning to use electronic devices to conduct data collection. And I brought with me one of the tablets that we're going to use. I have no shares in the company, but just an example. And we have, in addition to the NTP, we have a local research institution, which is one of the partners in the study. And it's called Dodowa Health Research Center. They're a research branch of the Ghana Health Service. And they conducted the previous cost study.
15 minutes.
And so we have, for data collection, we have 4 teams made up of 4 interviewers and 1 field supervisor. And each team covers a different area of the country. And in making up the teams, we had to ensure that they'd be able to cover the main 13 local languages spoken in Ghana. So factors that are driving the budget size, that require quite a lot of work. And so it's funded by USAID. I'd like to acknowledge that as part of the general technical assistance work that we provide to the country. And the total budget is about 58,000, but that doesn't include LSHTM salaries and international travels. And as you can see, data collection accounts for the biggest size, the biggest proportion of cost. Right, so where we are at now, so the process of setting up this survey has taken several months. But we are now, I'm heading to Ghana actually on Sunday for the training to start off the survey and the training week. So really watch this space, and hopefully at the next conference we'll be able to share with you some results. And thank you very much, and like a number of people I'd like to thank.
Thank you, Deborah. We're going to put the other patient and have the questions all at the end. So I'm going to introduce Kerry Viney, who's a research assistant from the Australia National University, or research fellow, sorry. But I think that study in Ghana is an excellent opportunity to see how TB patients are accessing different forms of social protection, since the myriad is so great, and it will be a wonderful study to stay tuned to.
Thank you, Anna, for the introduction, and good afternoon, everyone. I deliberately kept my presentation very brief, knowing I would be the last presenter, so I'm hoping that we stick to time, and very happy to discuss any aspects of this afterwards. So firstly, I'd just like to acknowledge my colleague from Australian National University, Dr. Susanna Vasneri. She was meant to present this presentation but couldn't be here, so I'm doing it on her behalf. So as you can see from the title of the presentation, I'm going to talk about patient cost surveys being implemented in 2 countries in my region of the world, near Australia, so Timor-Leste and Solomon Islands. So firstly, conflict of interest, and we'll move on. So just briefly, in the next 10 minutes or so, I'm going to provide a very brief background and rationale, and I think we've heard already that some of the background policy statement is really the information from the NTB strategy and the concern about what TB patient costs are spending. just briefly talk about the country context for both of these countries. Some of you may know these countries, but just provide a very brief overview of the context. I'll then talk about the progress to date with regard to survey planning, and I should emphasise that we don't have any data. Well, we do have a little bit of data yet, but we are just in the planning phase and we're hoping to start implementation at any point soon. Talk a little bit about some of the challenges and suggestions to perhaps refine this process going forward. And then finally, I'll end with some additional research ideas that have been suggested by the staff from Solomon Islands and Timor-Leste. So I guess the background really is partly, as I've just mentioned, the policy of the NTB strategy that we have and this indicator of zero catastrophic costs, but also a genuine concern and observation for what TB patients are paying for their care. Now, after the World Health Assembly approved the strategy in May 2014, we had discussions with some Pacific Island countries and territories about how they would manage this indicator. So we were talking to them about this, and funding continually came up as a problem. However, there was a small funding scheme available through our university, and that required that we collaborate across centres, and fortunately Susanna and I were in different centres. I had done a lot of work in Solomon Islands, Susanna in Timor-Leste, so we chose those as the survey sites. They had also previously indicated that they were wanting these surveys in their countries. We had some additional funding provided through the WHO country offices and WIPRO, although we still have a gap in funding, and we've had technical support provided by our headquarters of WHO, in particular Knut, Ines and Andrew. So, and I should just say, we are implementing the generic protocol and questionnaire, as has been described by the other presenters. So just a bit of a map to show you our part of the world and where these two countries are, and you can see that they're actually quite small countries. So if I can get the pointer to work, yes, this is Solomon Islands here, and this is Timor-Leste. So Solomon Islands is about 2 hours flight from Brisbane in Australia, and Timor-Leste about an hour and a half from Darwin. So in terms of the country context, I'll just briefly describe this, and I think this is important when we think about how patients access care. I'm a bit more familiar with the Solomon Islands context. It is an archipelago of about 900 islands in the Pacific Ocean, so you can imagine some of the challenges when delivering healthcare to a country that has 900 islands. They're not all inhabited, but it's still challenging. Very small population of 500,000 people, and they report about 400 TB cases a year, so the notification rate is about 90 per 100,000 population. Now, fortunately, they have very low rates of drug resistance, so hopefully we won't see some of those figures for MDR-TB that have been presented, and very low rates of HIV co-infection, and I think they've only had 1 or 2 patients who have had HIV co-infection, so it's very low. They are a lower middle income economy, and they have a low human development rank when classified by the Human Development Index. Now for Timor-Leste, Timor-Leste is the eastern half of the island of Timor, completely surrounded by Indonesia and only gained independence from Indonesia in 1975. Has a slightly bigger population, 1.2 million people, and a lot more TB. So it has about 3,500 TB cases notified per year, and a very high TB incidence rate, close to 500 per 100,000 population. Unlike Solomon Islands, they do have a problem with drug-resistant TB and low rates of TB-HIV co-infection. Similar to Solomon Islands, they are a lower middle income economy and slightly higher on the Human Development Index, and they're ranked as a medium human development country. So that's just briefly the country context. Now, as I mentioned, we have adapted and we're implementing the generic protocol and the generic questionnaire that were developed at headquarters. And this is just a summary of where we're at with both of these studies and how we're going about implementing these studies in the countries. So firstly, for Timor-Leste, we have very small sample size, so we use the same sample size calculator that Deborah has just presented, using very similar assumptions, and we just need a sample size of 445 patients. We are not doing a cluster sampling in Timor-Leste nor Solomon Islands because we have a low number of patients required and we have a limited number of health facilities. So we're approaching patients consecutively as they're diagnosed with TB. We are including adults and children, as long as they've been on TB treatment for at least 2 weeks. And we're recruiting them from 17 health facilities in Timor-Leste, using trained nurses as the interviewers, and the training just happened 2 weeks ago, actually. Now, the budget is probably a bit lower than some of the other budgets, and it's a bit less than what we need, actually. So these have been fairly low-cost surveys, costing about 20,000 Australian dollars. But I think one of the challenges for us is that we did underestimate the budget, and we're now looking for extra money because we want to have a bit more close supervision. Now, for Timor-Leste, it will take us about 5 to 6 weeks to complete the survey, so it should be completed by the end of the year, which is great, and we'll be analysing early next year. So for Solomon Islands, it's a very similar picture, a slightly lower sample size of 211 patients. We're enrolling them the same way, so we're doing consecutive enrolment of patients as they're diagnosed after they've been on TB treatment for 2 weeks. We're also enrolling adults and children. We're enrolling from 9 health facilities, which are DOT centres located at provincial hospitals and the National Referral Hospital. And same story as for Timor-Leste, we're using trained nurses as the interviewers. Similar costs in Solomon Islands, 25,000 Australian dollars. And because we have fewer TB patients diagnosed in Solomon Islands, it's going to take us about 9 months to collect information on those 211 patients. So this is just a map of Timor-Leste, and the red circles there are the health facilities where we'll be recruiting. So you can see there's a bit of a concentration in the capital of Dili, but the other health facilities are dotted around the country. And in Solomon Islands, it's a similar picture. We've got health facilities recruited from across the 6 provinces. So in terms of progress to date, I think I mentioned that we have used the WHO generic protocol and generic questionnaire. And we've taken those and we've done some training with the staff. So we are using web-based data collection as well, as Deborah mentioned, and as Ines mentioned, we're using the ONA platform, which so far has been really good. So we had to adapt those online questionnaires to the local situation though, and we did translate one questionnaire into Tetum in Timor-Leste. The Solomon Islanders were happy to have the questionnaire in English. We had to do some country-specific options in the answers to the questionnaire. So for example, some of the asset questions have to be tailored to the country situation, and we took those from the demographic health surveys that have been carried out in those countries. So as I mentioned, we have done the trainings for both of these surveys. So we did a 2 to 3 day national training in both countries, which covered a range of topics ranging from ethics in research, interviewer skills, and we went through every question one by one with the whole group to make sure that they got the meaning of that question, which took quite a large proportion of the training. We've developed some standard operating procedures, and implementation should begin any time in Solomon Islands, hopefully after this conference. And in Timor-Leste, implementation has just begun, and we've got 112 questionnaires currently completed. So this is just a few screenshots of ONA. I think Ines showed those as well. So it's just to show you the interface. And we found it to be a very easy to use interface, and actually the staff really liked it. And as Ines mentioned, it has all the skips already put in there. So we found it very easy for the staff to sort of pick up and learn how to use. So some initial challenges just observed through the trainings, I guess, and through developing the adapted versions of the questionnaires. I think Ines has already mentioned that the questionnaire is lengthy, and there have been some recent suggestions to shorten the questionnaire, and this was certainly reinforced by the staff in Timor-Leste, who found it particularly long. That didn't come out in the Solomon Islands training. Some questions are also complex, and there was some suggestion, particularly at the Timor-Leste training, to try and simplify how those questions are worded. We are using tablets to collect the data. I don't have one to show like Deborah did today, unfortunately. And I also don't have shares in the company, but we did find that some people struggled with the tablets. I think ours are a little bit smaller than the ones Deborah showed, actually, and I think if we did it again, we might buy slightly bigger ones. You do need quite a lot of training to use the tablets, particularly in countries where people aren't used to using smartphones, and certainly in Solomon Islands, people aren't commonly using smartphones. They all have a phone, but it may not be a smartphone. For the translated online questionnaires, Susanna's recommended that there are prompt questions in the local language, and she also thought that there should be additional prompts on the interface of the ONA questionnaire. Now, an interesting problem, I guess, in Solomon Islands came up that some women may not know their household income. So if we interview a female TB patient, the TB nurses and the staff, when we did the training, thought that some women who are, in the house, they're not earning an income, may not know their husband's income. So they may not know what the household income actually is. The other challenge in Solomon Islands is that patients are still hospitalised for the whole intensive phase. And I guess the staff in Solomon Islands thought they could just go and interview all those patients after 2 weeks, but the survey does require that some people are interviewed in the continuation phase. So we've had some discussions with them about how to practically do that and how having patients hospitalised for the whole first 8 weeks of treatment might impact on patient costs. And just, I guess, to finish up, some additional research ideas are rising based on sort of our discussions with the programs and with the staff at headquarters over the last few months. We're going to do a similar thing to Deborah, so we'll be doing a policy analysis of the social protection policies in each country, including a literature review. In Solomon Islands, they want to trace people who have been lost to follow-up to ask them about their costs. So they're very concerned about these people who have not returned for TB treatment, and they want to determine if costs were a reason why they were lost. We want to, as has been mentioned by other presenters, we want to link our survey data to TB treatment outcomes. We'd like to do some cross-country comparisons, maybe not just of the countries that we're working in, but we think more broadly speaking, some cross-country comparisons of TB patient costs would be useful. And we've also wondered about the role of active TB case finding on patient costs, and there was a study published recently from Cambodia which looked at this issue, and this might be something that we'll think about later. And finally, we wondered if the TB program should be collecting routine data on patient costs, so if it's something that can be put on a TB treatment card or in a TB register, and how that should be done. And I just added the last point here after going to the Global TB Symposium on Monday, I think it was. And there was a really interesting presentation on the patient pathway analysis, and I did wonder when I saw that presentation if that can somehow be linked to the TB patient cost data. So I guess I'll wrap up there. I wanted to keep it quite quick. So I just want to acknowledge and thank the people on this slide, including the staff at WHO headquarters, country offices, and the regional office in the Western Pacific region, Susanna from the university, and the national staff from the TB programs. Thank you.
Thank you so much, Carrie. Time is actually up, but we did promise some general discussion at the end of the session. So with the permission of the rest of the panel, and if you want, we can have another 5 minutes or so for general questions. Before I open up for that, however, I would like to say we can stay a little bit after the session for anyone, for example, from countries or partner organizations who are thinking about doing a survey and want to have more questions about practicalities, funding, technical support, etc. You can come to and talk to us afterwards. But let's see if you agree, if we can have a couple of questions from the audience. Diana, kick it off.
Hi, I'm Diana Weil from WHO Global TB Program, so also involved in the broader looking at how we can use this data for policy change, and also looking at social protection mapping. And we have a session on Saturday, as Knut may have talked about. So we have a plenary session for those that are the diehards that are here Saturday morning to come and hear Dame Margaret Whitehead and others speaking about efforts. But I wanted to ask a question to both Viet Nam and Myanmar, that both surveys suggest that beyond the broader issues of UHC and social support, some of the indications are that there are medical costs post-treatment or during treatment that might need to be addressed in the way that the TB care is being provided, or helping alleviate some of those post-diagnosis costs. So I was wondering if you had any sense from the surveys yet what those post-diagnosis treatment, costs might be, and how you might alleviate them, just from the actions you might be able to take as the TB program.
You first. Thank you, Diana, for questions. So for Myanmar, based on the survey findings, so we found that the cost is higher than in the after diagnosis compared to the pre-diagnosis. So that is mainly contributed by the MTR-TB patients, but it is due to the additional medications, foods, and the caregiver. As I mentioned in the presentation, the patient, foods, and the patient and caregiver time are major drivers. So then the next steps will be that we will disseminate all the survey results to the Ministry of Health and related ministries, like the Ministry of the Social Welfare and the Ministry of the Labor, especially on to focus on the social protections. So I think after the dissemination, we might engage the related ministries to set up the policies, especially on the social protections for both drug-sensitive and the drug-resistant TB in future. Yeah, thank you.
For Vietnam, we found that the treatment cost after diagnosis still there, and even lower than diagnosis. There are some possible factors that related to this reason. Firstly, TB patients in Vietnam are provided free service, medical service, and drugs. But the majority of TB patients have healthcare insurance. But the implementation of the policy in some area may be different from each other. Particularly, patients receive free TB drugs, but sometimes they have to pay for ordinary drugs, like vitamin and other type of drugs outside for those who are not have healthcare insurance. So the practice is not systematically in the whole country. So we try to convince local health authority to promote more healthcare insurance use in TB control, and also include non-TB drugs fees into healthcare insurance. Secondly, in Vietnam, even TB patients have health insurance. They still have to pay for some co-payments to limit service abuse. And now, for NTP perspective, we try to convince that we should support completely 100% for TB patients. We want to remove co-payment that apply for other diseases. So we are in that process. And as I mentioned earlier, while waiting for national policy, we try to develop social and charity fund to support for TB patients, to pay for the co-payment, and even to support for other costs, non-medical costs. But the process still going on. So hopefully we could launch the fund very soon. Thank you.
Thank you. So let's have one more question from the gentleman over there. Two more questions. Go ahead.
Yeah, for the last speaker.
Could you introduce yourself?
The last speaker.
Yeah, could you introduce yourself?
Okay, I'm Dr. Joe Ajubiwe from National Hospital, Abuja, Nigeria. She told us that household income, okay, for women, they don't know, they couldn't answer. But her work will be on TB patient cost survey. Why are you so particular about women alone? Then for the previous speaker, okay, he talked about 50% reachability in Ghana. Is it in the northern part of Ghana alone, or both sides? Thank you.
Okay, I might go first. Thank you for the question. This concern was raised by the TB program staff because you do have to ask questions about the household income in the survey. And it was thought that for the female TB patients who are not working, they may not know what the household income is. So they're going to sort of use some probing questions. And the other thing that they said is often the husband will be with the woman. So yeah, this is just a concern that was raised by them. So does that answer your question?
But your topic is TB patient cost survey
Yes.
in both sides.
Yes.
You weren't talking about just women.
Yes, yes.
Why didn't you include the men?
That's a good question. I think that's a cultural issue, and I guess once again that was something that they raised, that women are often at home in that particular culture, particularly outside of the cities. So it's often the men who are working, and they thought the men will know their income, but the woman is often dependent on her male spouse, and they thought that the women may not know what their husband earns. But yeah, does that make sense?
Okay.
Yeah.
Now, the previous speaker, please, on the 50%.
Yeah, thanks. I think 50% is an average value for the country, but we think that in some areas it could be even worse.
So, Jap?
You're working on a very high-level indicator in the SDG targets. So the robustness of that indicator is of prime importance, and I know that will be at the forefront of your mind. And I was happy to see in the Viet Nam presentation that with the 20% cutoff point, about 60-70% experienced this patient cost loss, but that about 25 to 30% would characterize it themselves as being very high costs or moderate costs. Anyway, how to deal with that in the development of your indicator, you may want to comment on it or not, but I just want to signal the importance given the high levelness of the indicator. Then a few conceptual remarks. The highest cost presumably are in households where patients do not reach diagnosis and die. And this should be, of course, be made very clear that, so actually you're seeing the positive tip of the iceberg. Yes. Secondly, maybe it's interesting to relate it to the treatment costs in the program, one way or another, or give that as a contextual background in the publications. And thirdly, I was thinking it would be very interesting also perhaps to consider to do such a survey in an industrialized country. Because, of course, the medical costs are enormous. So probably the patient costs will dwarf, but you don't know. And thinking it through, you may find also here something interesting that provides further context in the development of this indicator.
No, I mean, I want to comment on the industrialized country. Indeed, it's really important, I think, and this was made in a session by a colleague there also earlier this week, is we've kind of assumed that particularly in countries with a high degree of protection through the health sector, that you don't get these kind of patient costs. Yet the reality in many high industrial countries is you do in transportation and income loss, so that is not properly protected to the extent that it needs to be. So I would just like to concur with that last suggestion.
Yeah, thank you. I think it's a really important one, and it's a good opportunity to repeat what Diana said. On Saturday morning, we have this plenary on social protection, and there will be a UK patient who will tell her story about all the social and economic implications of TB that she had. So please come to that session, and that will highlight the importance of also sustaining health insurance and social protection schemes in high-income countries which are consistently under threat. Now, to come back, I think if there are no more questions, I'll try to wrap up and at the same time address some of the issues that you raise, Jap, which are critical ones, and they are related to the methodology, the validity of the measurement, and it's going to be really critical that we get it as right as possible, because it's one of the high-level indicators for the end-TB strategy, and the world is going to watch that. And indeed, I would say we have spent a lot of energy in the task force that came up with the generic protocol, building actually on 15 years of experiences in this field. So there is a lot of experiences, but there are still some challenges. Next year, mid-spring, we're going to have a follow-up task force meeting to look at all the survey results available by then, and we hope to have another 5 to 6 countries with data by then. That is the time to start looking in detail at the different methods that are being tried out with this protocol to revisit the question about the threshold and what is the appropriate one. Should it be a global one? Should it be different ones for different countries? Should we have sensitivity analysis and present the results based on different thresholds? These are all critical questions, and we're putting a lot of good brains together to try to sort this out. So that's sort of ducking your question a bit, but it's rest assured that we're going to continue to pay a lot of attention to the methodological issues. Now, having said that, I think maybe along some others on the panel, we're coming at this little bit from a research perspective. You know, we're really concerned with the methodology. We want to get it right. That is important. But I would like to emphasize that the results that you have seen today, they are actually confirming what we have seen in previous studies that have been using slightly different protocols. They all tell the same story, that the costs can be really high. And if you put together the medical cost, the non-medical cost, and the income loss, what we see is that many TB patients coming out of poverty are thrown into even deeper poverty at the end of what may be considered a successful TB treatment. Now, if I had an activist hat to put on, I should probably raise my voice and scream at you and be really upset. And for those of you who have been around for a while and listened to the advocates talking about all the things that are not happening in the right way, this is one of the fields that really needs a lot more attention. And I would like your help and to spread the word that, you know, at the same time we discuss the validity of and the details of the methods. Let's use the data that we have to push that message really, really forcefully forward. That one, everything needs to be free of charge. Not only the TB-specific stuff, but the adjuvant stuff for the diagnosis and the treatment that is needed. The service delivery models need to be conducive for patients' realities, because otherwise it's not going to work. It's about getting access, it's about staying on care, and it's about not doing that at the expense of really severe economic implications. And beyond that, it's about tapping into using the things that are happening in the space of social protection, social welfare, income replacement in the case of sickness, which is not an NTP agenda in the end of the day. It's a broader development agenda. But those things are really critical. They need to happen, and without it, we're not going to reach the epidemiological targets that are set out in the end-TB strategy about TB incidence and TB deaths. So I just want to reinforce that again. The indicator we have, it's an indicator, okay? We're going to monitor it, but it also reflects some critical steps that are needed in order to get to reduction of TB incidence and TB death rates. I'll stop there. And Anna, do you want to add something before we close?
I think it's fine.
Okay.
You've said everything.
Okay. Should I raise my voice even more?
No, it was good enough.
Okay. So thanks all for coming. Thanks to the panel. Great presentations. And next year we should have another one with even more data and implications for policy. So thanks for coming.